Everybody, and thank you for attending our MSK session. Today we'll be starting the International Skeletal Society session, and we have all our guest speakers are from different part of the world, and they are presenting the ISS. Our first presentation will be delivered by Dr. OMAR ALBTOUSH. He's from Jordan University. He's an associated professor, and he also works in King Hussein Cancer Center. And he will be presenting a talk about the frozen shoulder.
How to turn it on? Oh, it's okay. Hello, everybody. Hello, everybody. My name is Omar ALBTOUSH. I'm Associate Professor of Radiology at University of Jordan, musculoskeletal radiologist at King Hussein Cancer Center. And by the way, it's a pleasure of mine, really, to be with you here in Hurghada and as always in Egypt. So today I will talk about frozen shoulder and MRI imaging of frozen shoulder. So at the beginning, adhesive capsulitis has been defined primarily as a clinical diagnosis. So it's a clinical diagnosis. This is very important because sometimes when we evaluate MRI images, we think that there may be edema at the axillary recess, thickening at the rotator interval, and so on. So this is very important to call the patient or to call the primary physician to know if there is classical symptom regarding, for example, pain or limitation of motion. Adhesive capsulitis, it can be, another name of it is arthropfibrosis, a process in which the body forms excessive scar tissue or adhesions across the glenohumeral joint. Etiology is not fully understood. In fact, there are several factors. For example, it's worth mentioning that it can last for 3 days and then spontaneously resolve by itself. And medications mostly used, NSAID, painkillers, and also steroids. Imaging will exclude. The importance of imaging is not only to diagnose frozen shoulder and also to exclude other causes, which can be very apparent on MRI scan. So here, in fact, we have primary versus secondary causes. Primary, idiopathic, we don't know the etiology. Secondary, it can be due to trauma or long history of immobilization, for example, after fracture of the humerus or so on. And an increased incidence, we have also multiple association. So it's associated with diabetes, associated with hyperparathyroidism, associated with Parkinson's disease, COPD, autoimmune condition, and Dupuytren disease. So here, for example, this is not to memorize, just to have an idea. Association with type 1 and type 2 diabetes, it's about 10% and 22%. And also, diabetic patients have worse prognosis compared to non-diabetic patients. Hyperparathyroidism increased risk by 1.2. CVA disease as well, Dupuytren disease found in 52. This is strong association. And because of that, there was a theory that both conditions are the same by histopathology. So here, in fact, we have in Dupuytren disease, we have fibroblasts which will transform to myofibroblast, and it will result in the contracture, which is the hallmark of the condition. Multiple theories regarding the development of it. For example, metalloproteinase is involved in scar remodeling. It will be not present in adhesive capsulitis. Type 14 will be not present. Type 1 and type 2 will be less. Findings include loss of synovial layer of the capsule, adhesions, as we will see also adhesions. It can be adhesions to the capsule itself, I mean to the axillary recess, and adhesion with the bone, with the humerus neck. thickening and fibrotic rotator interval, also one of the important manifestations of this condition. Okay, what about oncology? This is important. In fact, the reason behind presenting this topic, I'm working in a cancer center, and we always scan patients with contrast. Sometimes, to be honest, sometimes they have only pain. If someone asks me why to give contrast, I will say that it was done routinely by contrast. But we have found an important finding that contrast will increase the diagnosis of frozen shoulder. So when I return back to the patient and ask him if there is any symptoms of frozen shoulder, surprisingly, it was really strong association. So I will show you some images. So it's worth mentioning that in solid tumors, it's associated in hematological malignancies and can be frequent complication of mastectomy. Also, it's in differential diagnosis of paraneoplastic syndrome. It can be, for example, predict some cancers like lung cancer. This was breast cancer and non-Hodgkin lymphoma. Chemotherapy also is a cause of frozen shoulder. Angiogenesis is the hallmark behind the chemotherapy effect and resulting in frozen shoulder. Okay, now we move to the most interesting aspect. Okay, I will show you two cases. Please have a look here. Okay, this case was, sorry. Okay, this was a routine case in the institution where I'm working. So as you can see here, if I want to just to describe the findings, I will say degeneration of the AC joint. For example, we have mild subacromial subdeltoid fluid. We have minimal joint effusion. Okay, you might see here also that there is bursa fluid signal surrounding the long head of biceps, and the bursa we have already mentioned. But please have a look. This is the same patient with this appearances. So you see this was post-contrast enhancement. Can you see the extensive diffuse capsular enhancement appreciated, for example, here at the rotator interval and the axillary recess, and also the whole capsule of the joint. And when referring back to the patient, just simply, I asked him regarding limitation of motion. It was positive, and to be honest, more than 80% of our studies without contrast, it show no changes of adhesive capsulitis. And when we do contrast enhancement, there will be something like that. And this was not routinely done in our institute. This was done routinely in our institution. I mean, it's not routinely part of the assessment of the adhesive capsulitis. Okay, this is the first case, second case. Okay, I think it's the same one. So we can return back to our lecture. So here, what's the hallmark to diagnose adhesive capsulitis? In fact, there was really many signs in order to do that. For example, thickening of the coracohumeral ligament. This is coracohumeral ligament. This one on sagittal, and we have here the subcoracoid fatty triangle, and here this is a thickened coracohumeral ligament. So even with thickening of the coracohumeral ligament, there was a study shows the cutoff of 4 millimeters. However, another study shows 3 millimeters. Some of these measurements are not. I mean, you need to ask the patient clinically, and also you need to take the whole scenario. I mean, to know the clinical aspect and also to take the whole scenario. To be honest, I will not report adhesive capsulitis unless there is. I mean, if I have MRI with contrast, unless I have enhancement post-gadolinium, and also as well thickening of the axillary recess. But this is an important sign, coracohumeral ligament thickening. Usefulness of capsule thickening measurements in axillary recess of diagnosis of adhesive capsulitis. It was reported that it's more than 4 millimeters. However, another study didn't show any importance to measure it. So, Mingradi et al. Didn't find significant thickening at the axillary recess in patients with adhesive capsulitis. This is our case, and this was, as you can see, this is the thickening we are describing. Just to let you know. Other signs, for example, the sensitivity of MRI imaging in diagnosis of adhesive capsulitis increase with the use of contrast enhancement. This is the same patient, which I have already presented. As you can see, this is the axillary recess, and here we have the diffuse enhancement at the axillary recess. So sensitivity of evaluation will be increased from 63 to 85%. And specificity, of course, will raise from 86 to 91. Thickening of the joint capsule at rotator interval and in the axillary recess. As you can see here, we have thickening, diffuse thickening at the rotator interval. Rotator interval, as you know, it's the space between the supraspinatus and the subscapularis muscle. And as well, this is the thickening at the axillary recess. We have obliteration of subcoracoid fatty triangle. I will show you this one. This is subcoracoid. This is the coracoid process. And we have here preserved fatty signal. On this one, as you can see, we don't have this triangle, so it was obliterated. So for example, in order to look for this case, this is a normal case. I mean, there is no changes of adhesive capsulitis. As you can see, we don't have thickening. What are the signs we are looking for? We don't have thickening at the axillary process. We have degenerative changes here of the AC joint, and we have tendinosis. This is the coracohumeral ligament, thin. We have preserved triangle. So 1, 2, 3. These are the signs we are looking for. This is another view of the axillary recess. This is a positive case with adhesive capsulitis. As you can see here, we have thickening of the axillary recess. We have here thickening of the coracohumeral ligament, and we have loss of fatty signal at subcoracoid triangle. This was post-gadolinium. As you can see here, we have enhancement. Of course, this is without contrast. Here we have enhancement, as you can see. And we have also enhancement, heterogeneous enhancement at rotator interval. So here, adhesive capsulitis is self-limiting disease in which particularly in initial stage physiotherapy and medication are important. So this raises the point that we need to do MRI scan in order to exclude any other causes, like, for example, calcific tendinitis. So for one of the treatment options for calcific tendinitis, to do lavage and so on. So this condition is treated with the physiotherapy and also with medications. I used to do a distinction for it, but to be honest, it was not successful. It was a fluoroscopic guided distinction. It's a very painful procedure for the patient, and the outcome is really poor. Adhesive capsulitis usually present with the 4 stages. In fact, I'm mentioning, so this is a clinical staging system, but why I'm mentioning that? Because there was reports describing association between these stages and what we can see on MRI scan. So here, I will show you the stages, and when I return back to this. Okay, so stage 1. Stage 1, the patient will come with pain and preserved motion, no limitation of motion, and arthroscopy will show synovitis without adhesions. So this is a clinical and arthroscopic staging. Stage 2, there will be stiffness, and arthroscopy will show synovitis. Also, there is loss of the axillary fold. It's an indicative of early adhesion formation. Stage 3, it's a global loss of range of motion and pain. As you can see, pain here and pain. And here pain will be less, Arthroscopy will show obliteration, whole obliteration of the axillary recess due to the adhesions. And stage 4, it will be no pain, and arthroscopy will show advanced adhesions. So this is the reason here, especially in stage 1 and 2, patients suffer from pain, which usually diminish in stage 3 and 4, and it will be more limitation of motion. The significance of us, that several studies try to correlate these stages with MRI imaging. For example, here, they have found an association with contrast enhancement of the joint capsule in the axillary recess with shoulder pain. So they simply thought, if I see a contrast enhancement, the patient will suffer of pain if he had adhesive capsulitis. Second thing, they found a significantly increased pain score in patients with enhanced deposition of contrast media at the axillary pouch. So there was stagnation of contrast media or delayed enhancement of contrast media at the axillary recess. So they tried to know if there is any correlation with these stages by MRI images. Before finishing my talk, I will show you the first. Okay, this is a routine case. So, as you can see here, we have preserved alignment, we have edema and apparent thickening of the axillary recess. We have also degeneration of the AC joint, we have fluid, we have edema also at the rotator interval. This is a STEER images. This is PD. And on STEER images, as you can see here, same changes. This is the axillary recess and this is the rotator interval. I will show you the post-contrast images. Please have a look here. There is diffuse enhancement, dorsally, up, down, at the axillary recess, at the rotator interval, and also ventrally. This appearance is universal. I always see this appearance when I call the patient will report or will claim limitation of motion and also severe pain. There was also an improvement after steroid and painkillers, but it took time, mostly more than 1 year. I have been following some of these patients for more than 2 years till the moment. Thank you so much.
Thank you very much, Dr. Omar, for your comprehensive and very good, excellent presentation. I think we have a couple of minutes for questions, if there is any questions for Dr. Omar. Yeah.
Yep.
Thank you for the good presentation.
Thank you.
I want to ask you about the protocol, your protocol. In adhesive capsulitis or frozen shoulder, do you start up with contrast? Your protocol routinely includes contrast? Because as we know, the age of most of these patients is their older age, renal impairment, gadolinium. Some of the patients do not prefer contrast. So what do you do about that?
Okay. Thank you. This is an important issue. In fact, you know, what we are facing from real life scenario, that the indication will be pain. Sometimes they are looking for metastatic process. They need, because I'm working in a cancer center, so the whole issue, they want to exclude any metastatic process, something like that. Sometime in PET scan or in bone scan, there will be enhancement at the region of the shoulder girdle. So they want more to analyze this. So, I mean, in my case, mostly contrast will be incorporated as routine protocol. But if you are asking me regarding my opinion to use or not to use, of course, if there is any problem with the renal impairment or so, okay, this will be, we will not start with contrast in old age or so on. So we have criteria. But I mean, if you are asking me if there is a patient with suggestive symptoms of or suspected to have adhesive capsulitis and he has no renal impairment or so, I would strongly recommend the use of contrast media. In really, okay, I cannot show you, for example, 40 cases. In the 40 cases, what we have is the same of this scenario. So you will see only edema at the axillary recess. I will not suspect, to be honest, adhesive capsulitis. And after contrast injection, I will see the whole capsule will show very intense enhancement. And when I return back to the patient, he will describe classical symptom of adhesive capsulitis. So, okay, short answer, I would recommend that, yes, in cases with suspected adhesive capsulitis.
Thank you, Dr. Omar, for your presentation. But I have a question about the contrast in adhesive capsulitis. As we know, the frozen shoulder we confronted is in stage 4, in which there is fibrosis. What's the benefit of contrast in such stages? No synovitis. There will be no enhancement.
Yeah, this is right. The most uptake will be in first and second and third stage. On fourth stage, we can see that there is fibrosis, there is low signal at the axillary recess, and sometime there will be adhesions, as I have mentioned. With the axillary recess, it will be obliterated, and even in one case, I have seen that it was really tethered to the bone. So if just you call the patient, you ask the patient, he will describe a classical symptom of adhesive capsulitis in such if you don't have intense enhancement like in stage 4.
Yes, right. We depend upon the clinical scenario and the signs you mentioned.
Yeah,
the thickening, the fold, thickening of the rotator interval. But in the early stages, how would you differentiate it if you give contrast between these, if it is an inflammatory arthritis or frozen shoulder?
Inflammatory bursitis? You mean
arthritis. If there is synovial enhancement, as you mentioned.
Okay, in inflammatory arthropathy, let's say it's apart from if it's, if it's related to autoimmune condition or infectious process, I would always see effusion of the shoulder. But in frozen shoulder, in the cases, there will be mild effusion. So the hallmark of issue, you don't have, for example, pus. It's not infectious process inside the joint. You have the capsule itself is thickened. So I think by joint effusion, to assist the joint effusion, it will be less. Second thing, I always, if I suspect infectious process or so, I would recommend aspiration, apart from any clinical scenario.
Thank you.
Okay.
Thank you, Dr. Omar. And if there is any questions, Dr. Omar will be available at the end of the session. So now we'll move to the next presentation.